Hello friends, uh, I am Dr. Devender Bairwa and I have done my DM Clinical Immunology and Rheumatology from Chippa. Previously, I was working as senior resident in Rheumatology AIMS Delhi. I did my MD Medicine from AIMS Delhi and MBBS from AIMS. Teaching is my hobby and I love to teach. And I welcome you all to this particular lecture. And this lecture topic is Azotemia and Urinary Abnormalities. This lecture is for MBBS students as well as PG students, and little bit of it can be helpful for the people who are doing BSc nursing or paramedic sciences. If you do have any doubts or you want to have any clarifications, you can put your queries in the comment box. I would try to help you and we will reach you. So we'll start this topic. This is chapter 52. The slides are based on Harrison and a few inputs from the net or from the other references. And we have tried to keep it as simple as possible. So let's start this topic. So we will be discussing this presentation under the following headings. First, we'll see few case scenarios to stimulate you. Then we will see symptom complex of urinary tract. Then we will see how to approach a patient with azotemia. Then we will see how to approach hematuria, and proteinuria, and then polyuria. And then we'll be concluding this presentation. So let's say one case scenario. A patient has presented with reduced urine output, raised serum urea creatinine, and vomiting and anemia. All of the following suggests that the patient is having pre-renal acute kidney injury, except your options are A. Urine specific gravity 1.020, B. Urine osmolality is equal to 500 milliosmol per kg of urine, C. Fractional excretion of sodium, that is FeNA, is more than 2%, or D. Presence of hyaline cast. The other question is, a patient with chronic kidney disease is planned to be looked for renal scarring, that is the static scan of the kidney. The scan to be ordered is, your options are A. DTPA scan, B. DMSA scan, C. Mark 3 scan, or D. Muga scan. The next question is, presence of the following in the urine suggests glomerular diseases: RBCs, WBCs, protein, or RBC cast. I will not be telling you the answer of these three questions, and I hope that once you see this presentation completely, you will be able to answer these questions by yourself. So let's start. So we will start first with the basic understanding of urinary tract symptom complexes. Now understand this, that our body is having kidneys. There are two kidneys. First, let's understand what is urinary tract. We have two kidneys, then we have ureter, and then we have bladder, and then we have urethra. So roughly 20 to 25% of cardiac output is going towards kidney. It has very high blood flow rate because it has to filter the blood, and then whatever blood is filtered, all the waste along with the waste water is excreted from the body in the form of urine, and it contains lots of waste as well as electrolytes. So now simply we can understand, if kidney kidneys are functioning properly, then there will be adequate urine formation. If by any region or by any disease, if the kidneys are not functioning well, then your urine output will reduce. Let's see what different kind of urinary abnormalities can be seen in a patient who is having a problem of genitourinary tract. So there can be diseases of urine volume. It means urine volume can increase or decrease, or there can be disorder of urine content. There can be some abnormal contents in the urine, or there can be disorder of micturition. It means the passage of urine is difficult. There can be diseases of chronic genitourinary pain, or there can be disorders of genitourinary tract infection. In urine volume, we can see there can be increased volume of urine, that is known as polyuria. If the volume of urine in a day is more than 3 liters, you call it polyuria. If the amount of urine has reduced because of any reason, less than 400 ml per day, then you take it like oliguria. If there is no formation of urine at all, by definition, less than 100 ml of urine, per day is known as anuria. In case of disorders of urine content, you can have hematuria when there is presence of blood. This blood can be in the form of RBCs, or there can be a gush of RBCs. There can be very minute to very massive hematuria, or there can be presence of RBC cast also. Everything is known as hematuria only. There can be presence of WBCs in the urine, known as pyuria, or there can be presence of hemoglobin in the urine, known as hemoglobinuria, typically seen in cases of intravascular breakdown of RBCs. And there can be presence of urinary cast, RBC cast, WBC cast, epithelial cast, and other casts. Generally, cast they are being originated in the nephrons. Then we are coming to disorders of urination, micturition. Patients can have difficulty in passing of urine. They can have symptoms like nocturia. It means increased frequency of urination in the night, or there can be hesitancy. It means difficulty in passing the urine, or there can be increased urine frequency. There can be urgency. It means patient as soon as patient wants to go to urine, he feels that as if the urine will leak out. This is because of detrusal hyperactivity. Or there can be dribbling or the poor urine stream if there is some kind of obstruction or poor force to produce menstruation force. Apart from that, disorders of chronic genitourinary pain, we can have urologic chronic pelvic pain syndromes. We will discuss about these disorders in the discussion of the one other chapter of interstitial cystitis and painful bladder syndrome. And then there are disorders of infection, UTIs. It means urinary tract infections, or there can be sexually transmitted diseases. Now we also know them as STIs. So UTIs and STDs are out of the scope of this discussion now, and we will discuss these chronic pelvic pain syndromes in some other lecture. So let's say we generally don't measure the 24-hour urine volume, and then we don't collect it and then see how the kidney is functioning. We know every minute lots of blood is going towards kidney and being filtered, and we have to measure it. And the simplest term of measuring it is GFR, that is global filtration rate. So creatine is one waste product produced by mostly muscles, and it is being filtered by kidney. And if we can calculate creatine clearance, then roughly we can calculate GFR. And the values for normal GFR in males is 125 ml per minute, and female 115 ml per minute. So GFR means nothing but the amount of blood that is being filtered by the kidneys per minute. So creatine, if we know the creatine value in the urine and the serum, then using this formula, as we can see in this thing, we can reduce the roughly we can calculate the GFR value with the help of creatine clearance. But practically we don't see urine creatine value or serum creatine value and to calculate creatine clearance. We have different kind of equations and formulas to roughly reduce the GFR rate, and we have three different formulas. One is Cockcroft-Gault equation, then we have four variable modification of dietary renal disease, and then we have CKD EPI equation. So out of these three, CKD EPI is now considered relatively better and can be used to calculate your EGFR, estimated GFR rate. In general, the amount of creatinine which is being produced in a male or female, the rate is here 18.5 to 25 milligram per kg body weight creatinine is being produced in a male of 20 to 50 years of age. And in women, it is from 16 to 22 milligram per kg body weight. So you can use this thing later on. I'll tell you how to use this information to know whether the amount of urine that has been collected in 24 hours is adequate or not. Okay, so apart from creatinine, now they're talking about cystatin C. It's a protein, serum cystatin C, and they're thinking whether the cystatin C can be another surrogate marker for GFR calculation apart from creatinine. It has been proposed to be more sensitive marker of early GFR decline than plasma creatinine, but the problem is it has got so many variables which can affect the value. Like there can be increase of cystatin C because of diabetes, smoking, inflammation, and even the male and female values are different. So far, right now, in practicality, we are using serum creatinine value and then using the same by using Cockcroft-Gault equation and four variable MDRD equation or CKD API. they are calculating the estimated GFR rate. So if suppose somebody's kidneys are functioning very well, then your eGFR rate will be roughly around 100 to 125. And as the kidney function will decrease, your estimated GFR rate will also decrease. So let's say if a patient has come to you with some kind of renal dysfunction, let's say urea is high, creatinine high, urine output is low, then how can you differentiate whether the patient is having this renal failure for a long time, it means chronic renal failure, or the patient has developed this chronic renal failure acutely. So there are few soft pointers which can differentiate acute versus chronic renal failure. And these points are, like in case of chronic renal failure, you will always get some kind of proteinuria roughly equal to 500 milligram or 1 gram of protein per gram of creatine, you can find it there. And in case of chronic renal failure, because kidney is not working at all, they will neither concentrate nor dilute the urine. Therefore, the urine osmolality will be roughly equal to the osmolality of your blood serum, blood plasma. And this is known as isothenuria. Apart from that, if you go for a renal scan in USG, you will be able to see that the kidneys are shrunken now, their size has reduced. Roughly the size of kidney is 9 to 11 centimeter from upper pole to middle pole. When you will see in the scan, then you'll be able to see that they're shrunken, they have gone to less size, 7 or 8 centimeter. Then the cortical thinning will be there. Apart from that, there can be differentiation of cortex and medulla of kidneys also lost. So these are some short pointers which can differentiate between the acute versus chronic renal failure. Now come to the cause of renal failure. So let's say if we divide the causes of renal failure, we can see that kidneys can have three kinds of your renal failure. One can be pre-renal, then can be renal, then can be post-renal. So understand this: kidney is dependent on the heart and good amount of blood flow towards it so that it can function. Suppose for any reason, if the blood supply to the kidney is compromised, kidney will not get enough blood and kidney will not work. This is known as pre-renal type of kidney failure. This is also the most common type of renal failure. So what can happen? Suppose if there is some intrinsic defect in your kidneys, suppose some toxin has been ingested and it is being secreted via the kidneys and the toxin has caused tubular necrosis. Or let's say if patient was having pre-renal kind of acute renal failure picture, no supply of blood to the kidneys, and with the prolonged ischemia, tubules they have undergone ischemia and necrosis, even then your intrinsic renal failure can occur. So there can be causes of there can be pre-renal type of causes of renal failure that can lead to renal failure, and there can be toxic injury to kidneys. Now, pre-renal and renal, after that, we can have post-renal causes. In post-renal causes, there can be some obstruction to the urinary tract. For example, there can be, let's say, stones are there, or let's say urethral problems are there, or bladder problems are there, that can lead to your obstruction can lead to black flow, and due to black flow there can be your renal failure. So if we see these types of acute renal failure, they can be either pre-renal because of poor perfusion of kidneys, they can be intrinsic renal diseases because of either prolonged ischemia, or there can be toxic injury to the nephrons, or there can be post-renal process. Out of these three, pre-renal failure is the most common. Post-renal process is least common but very easily to be diagnosed. Okay, now this figure is actually showing one, let's say this is schematic diagram of your nephron. Now we need to understand this, that what renal artery going into the kidney, and once it enters, then it forms some arcuate arteries and then small arteries, and ultimately we have formation of afferent arterioles. This afferent arteriole is going and forming glomerulus, and then efferent arteriole is taking blood out of it. So we know that in the nephron, from one end, afferent arteriole is entering and it is giving blood. Blood is entering through afferent arteriole in the glomerulus, and then there are lots of capillary plexus is there, that is glomerulus, and then there is efferent arteriole. Now we know if blood has to be filtered through it, then we have to produce a pressure gradient. That pressure gradient in the nephron is maintained how? By the help of action of prostaglandins and the action of your angiotensin. So what happened because of action of prostaglandins? This afferent arteriole is vasodilated, diameter increases. It leads to lots of blood flow in the nephron, and this your efferent arteriole is being constricted because of action of angiotensin. So it leads to a pressure gradient formation due to which the blood flow downwards uh, from glomerulus to the Bowman's capsule, then goes to the your collecting ducts and everything, and that's how the nephron is functioning. Suppose if somebody is already having a compromised kind of renal flow, in such condition, these mechanisms become more important. And suppose in such condition, if somebody is giving NSAIDs drug or ACE inhibitors, then what will happen? If NSAIDs are taken by the patient, then this dilation is gone, no blood flow to the nephron, and if this vasoconstriction maintained by angiotensin is also gone because you have an ACE inhibitor, and then special gradient is lost. Therefore, in the condition when there is a hemodynamic uh, decompensation in the patient, when there is a low blood pressure, or let's say patient is in shock, in such condition drugs like NSAIDs and ACE inhibitors are not good. They should be stopped, or if they are used, they should be used cautiously. Now coming to some values of blood and urine that can help us to differentiate between the pre-renal causes of AKI, that is acute kidney injury, from the intrinsic causes. Let's see what is the cause history. In case of your pre-renal AKI, generally there will be history of some volume loss, some dehydration, or let's say trauma, lots of blood loss will be there, or patient may be in hypovolemic shock, or patient can be in distributive shock or cardiogenic shock, and that's how the supply to the kidney is gone, and that's how kidneys are failing now. In case of intrinsic renal AKI, all the causes of pre-renal AKI can also lead to intrinsic renal AKI if they are for prolonged time. Apart from that, there can be nephrotoxic drugs, toxins that can lead to intrinsic renal AKI. Now, understand this: when kidneys are functioning fine, they can produce any amount of urine they want to. These want to. Now, understand. Suppose if kidneys are not getting enough blood, then kidney has to excrete all the amount of solutes, waste, in whatever reduced amount of urine it can form. Therefore, it means in case of your pre-renal AKI, the volume of urine will be less, it will be more concentrated, it will be containing more solutes, right? In case of your intrinsic renal AKI, because your kidney is totally gone now and it will not work, what will happen? It will not be able to neither concentrate nor dilute your urine. Okay. Now see what differences are there. I'll tell you each one by one, and then we'll try to understand why these findings are there. So let's see first specific gravity. Specific gravity is nothing. It is basically your density of the fluid. If the solutes increases in your fluid, then your specific gravity increases. As I already told you, in case of your pre-renal AKI, because the kidney is excreting more amount of solutes in less amount of your urinary volume, that is why the specific gravity is increased in case of your pre-renal AKI. It is generally more than 1.020. The one values of you the one reference values of water. Then in case of your intrinsic renal AKI, because now kidney is not concentrating the urine, then the specific gravity roughly becomes equal to the plasma specific gravity, that is roughly equal to 1.010. This is also known as isothenuria. Now coming to blood urea nitrogen and plasma creatine ratio. Remember, I told you that kidneys now they'll be excreting much amount of your waste in least amount of your volume. The ratio of blood urea nitrogen to plasma creatine increases more than 20:1 in case of your pre-renal AKI. While in case of your intrinsic renal AKI, the ratio is 10:15:1. This blood urea nitrogen is nothing, it is just the amount, the mass of the nitrogen part of the urea. And if you have to calculate urea from blood urea nitrogen or the other way around, roughly you can say that your blood urea nitrogen is equal to urea by 2.1. That means roughly if suppose somebody is having blood urea nitrogen of 20, then he will be having urea of 40. Okay. Now coming to urine sodium. Now understand this. We already know that the sodium primarily is being absorbed, retained by kidney in your kidney in normal physiology. So what happens in case of pre-renal AKI? Since kidneys are still functioning, they will be doing this principal function, and that's how they will be conserving your sodium in the body. Urine sodium will be less than 20 milliequivalent per liter. But in case of your intrinsic renal AKI, that function is gone, and that's how sodium is being lost. So the value is more than 40 milliequivalent per liter. Now coming to urine osmolality, I already told you urine is concentrated, it has more solutes. So in pre-renal AKI, urine osmolality is generally more than 500, while in case of intrinsic renal AKI, it is roughly equal to your serum osmolality, so it is always less than 350. Fractional excretion of sodium is low in case of your pre-renal AKI. I told you already why, and it is high in case of your intrinsic renal AKI. The ratio of urine creatinine to plasma creatinine also increases in case of your pre-renal AKI. It is more than 40, and it is less than 20 in case of your intrinsic renal AKI. Coming to fractional excretion of urea, it is reduced in case of your pre-renal AKI, less than 35%, and it is more than 35% in case of your intrinsic renal AKI. Now understand this. A patient who is who has to produce more concentrated urine. If you remember, we used to read in our physiology that there is a counter current mechanism, then there is something known as medullary tonicity, and then at the medulla part of nephron the urine is being concentrated. That concentrated urine formation will depend on the tonicity of the medullary part of the kidney. The tonicity of medullary part of kidney has to be increased if the kidney has to produce more concentrated urine. To produce more concentrated urine, to increase this medullary tonicity, more of urea is being, uh, let's say, reabsorbed and being there, being collected in the medullary part. So the medullary urea is increased. That's why the medullary tonicity is increased, and that's how the more concentrated urine can be formation. If you have to increase medullary urea, you have to excrete less of urea. That's how the fractional excretion of urea is reduced in case of your prerenal AKI, and it is more in case of your intrinsic renal AKI. Coming to your ratio of urine to plasma blood nitrogen, it is more than 8 in your prerenal AKI and less than 3 in case of your intrinsic renal AKI. If you see the urine picture, in case of your prerenal AKI, there will be nothing, or you can find hyaline casts. Hyaline casts are formed by your TAM horsefall proteins, and because in case of your prerenal AKI, less of urine is being formed, less of urine is there, a dehydrated kind of picture is there in the urine analysis, and that leads to inspission or let's say deposition of your these TAM horsefall proteins, and that will form the hyaline cast. In case of your intrinsic renal AKI, because of the necrosis of tubules, there can be shedding of some epithelial cells, or there can be some RBCs, or there can be some WBCs. All these cells are disintegrated, they are shredded, and they can form muddy brown kind of cast. In case of a pre-renal AKI, generally because glomerular function is well preserved, there is no proteinuria. Generally, there is no proteinuria, or there be just a trace proteinuria. In case of intrinsic renal AKI, depending on what pathology is there, and in the late stages of your renal intrinsic renal causes, this podocyte function is gone. So there will be some amount of mild to moderate proteinuria in these cases. There are no novel biomarkers for pre-renal AKI. But for intrinsic renal AKI, there can be increased concentration of kidney injury molecule 1, cystatin C, or NGAL. Cystatin C is a protein. NGAL stands for neutrophil gelatinase associated hypokaline. And then CYR61 is cytokine. All these can be increased. So in case of renal AKI, it is the fluid that all is needed. If you give amount of fluid to patient or fluid challenge, then patient's urine output will improve. Patient's blood urea nitrogen picture will also improve. In case of intrinsic AKI, there will be no response to fluid challenge. So all these findings and values can help you to differentiate between the pre-renal and intrinsic renal causes of AKI. There are some conditions where there can be intrinsic failure of your intrinsic type of kidney failure, but still there can be less than 1% of your fractional excretion of sodium. These cases involve your rhabdomyolysis, congestive heart failure, cirrhosis, and hepatorenal syndrome. Coming to the cast in your urine analysis, as I told you already, there can be two kinds of cast. There can be acellular cast or there can be cellular cast. In case of acellular cast, you have hyaline cast formed of protein. Then there can be your granular cast formed of some breakdown of cellular substances. Then there can be waxy cast because of the fat. Waxy cast, there can be fatty cast, or there can be RBC cast, WBC cast, epithelial cast, depending on what cells these casts are composed of. So we can see hyaline casts, they are formed of because of solidified 10 horsepower proteins, and these proteins are actually secreted from your thick ascending limb of nephron. And then you have granular cast, which are formed by breakdown of cellular cast or the inclusion of some kind of proteins in your these cast, and they generally indicate your chronic kidney disease. There can be waxy cast, they suggest long standing kidney diseases. Then fatty casts are there, generally seen nephrotic syndrome. Lots of fat globules are being excreted in the urine. RBC cast because of glomerular injury or glomerular pathologies. White blood cell cast because of pyuria, and epithelial cast are generally seen in case of your acute tubular necrosis of any cause. Tubular necrosis happens, epithelial cells in the tubules they will be shedded and they will go in the urine and they'll form the epithelial cast. Now, TAM horsepower protein, they are also known as uromodulin. We have to understand that what happens, these thick ascending limb of the nephron, it is producing these proteins, and these proteins, when they go into urine, they are actually anti-stone, they are actually helpful in preventing stone formation. So these proteins are the proteins which get inspissated and they form these hyaline casts. Now coming to post-renal azotemia, it means the post-renal causes of your renal failure. Now understand this: we have two kidneys. Even if your one kidney is functioning, this one kidney is sufficient enough to handle the load of two kidneys. Therefore, if in a condition if only one kidney is failed, kidney is not functioning, then that will not lead to your renal failure. So generally causes which leads to problem in both the kidneys, even in the post-renal causes, will lead to renal failure. For example, pathologies in your urethra, urinary bladder, or let's say involving both the your ureter. If such conditions are there, then they will lead to your renal failure. So, since single kidney is capable of adequate clearance, complete obstructive acute renal failure requires obstruction at the urethra or bladder outlet, bilateral ureteral obstructions, unilateral obstruction in a patient with a single functioning kidney. So, what happens generally when we do a USG in these patients, you can see that they are dilated ureters or they can be dilated renal pelvis that can be seen in the USG. This is known as hydronephrosis. And if suppose the obstruction is acute, in such cases, ultrasound examination may be negative. We can do some scans. There are DTPA scan, DMSA scan, Mark 3 scan. So these DTPA and Mark 3, they are dynamic scan of the kidney, and DMSA is a static scan of the kidney. Let's say a patient has come to you with acute renal failure. Patient has got very high urea, high creatinine. Patient has got azotemia and uremia. So understand this: azotemia is nothing but it is the increased blood urea nitrogen, and a uremia is increased urea. Blood urea nitrogen also involves many other component other than your urea. There is your uric acid is there, hypuric acid is there, and other molecules containing nitrogen waste are there, including some purines and pyrimides. So all these will form your waste products, and increasing all these is known as uremia. And uremia is the term used for increasing urea. So in one way, we can say that urea is a part of azotemia. Suppose a patient has come to you with renal failure, say urinary reduced, and then urea is increased, creatinine increased. Then this flow chart from Harrison is very beautiful, and it is showing how can we further proceed. So suppose a patient has come to you with azotemia. What you can do, you can go for a urine routine microscopy known as urine analysis, and then you can go for a simple ultrasound. Because post-renal causes are least common, but they're very easily diagnosed. This is why we are using a USG KUB here, and you can do a USG kidney renal bladder and you can see if there are any signs of hydronephrosis. Suppose if any signs of hydronephrosis are present there, like dilated ureter, dilated renal pelvis is there, or hydronephrotic changes are there, then you can look for a urological evaluation, and then you can relieve obstruction. Let's say there is a there is a tumor or there is some stone, you can remove it out. Suppose if you have done a USG but your renal size is normal and your urine analysis is also normal, in microscopy is normal. Then if kidneys are small, thin cortex is there, sediments are not there, isothenuria is there, some proteinuria is there, then probably you are dealing with a case of chronic kidney disease. If this is the condition, this is the case, if this is the case, then there is no point of finding out etiology, and then you have to manage this case as a case of chronic renal failure. Now, suppose if you've done a urine routine microscopy and that is showing presence of some abnormal urinalysis, there can be presence of bacteria, there can be presence of RBC cast, there can be presence of RBC cast, or there can be presence of RBC entered RBCs, or there can be presence of some sediment, some your let's say sediments are there or casts are there, or there can be some kind of urinary related abnormalities. So, depending on the findings, what we have found, we can have different suspicions. If suppose you are seeing bacteriuria, then you can think about pulmonephritis. If you are seeing some WBC cast, some eosinophil, then you can think about intestinal nephritis. If you are seeing your lots of RBCs, hematuria, gross hematuria, then probably renal artery or vein occlusion, or there can be bleed anywhere in the urinary tract. If you are seeing RBC cast and some amount of proteinuria, that means in nephrons glomerular injury has happened. That can be because of any there so many causes of glomerulopathies or nephritis. Immune complex diseases are there or vasculitis is there, then you can go for a biopsy. Suppose if you're not finding these things, but you're finding some abnormalities in urine, then as we have already discussed in the previous table, depending on the urine osmolatics and fractional extraction sodium, we can see whether we are dealing with a pre-renal type of acute kidney injury or a renal type of acute kidney injury. So this flowchart you can use in your patient who are presenting to you with uremia or azotemia, and you can able to uh, delineate what the cause is. So this is a snapshot taken from one patient, and it is showing how a routine report of urine routine microscopy is generally presented. We can see quantity, we can see color, pale yellow. Generally, the color is straw pale yellow. Appearance should be clear in the patient. There should not be any deposits, and reaction is acidic. Normal pH of urine can be 4.5 to 7.5. Generally, it becomes more acidic if there is a dehydration, or if there is renal AKI, and then specific gravity can be anywhere from 1.03 to 1.035. Different labs have different values. Here in this case, it's 1.015. Then protein, glucose, occult blood, ketones, bile salts can be seen in these reports. Presence of protein means proteinuria. Glucose generally seen in case of diabetic people who will be having some amount of renal glucosuria. Occult blood can be there if either the patient is female and menstruating, or there is some blood being lost in the urinary tract. Ketones are generally seen in case of starvation, and ketones and glucose, if together present, then they can be a pointer toward possibility of diabetic ketoacidosis in your patients of diabetes. Bile salts and pigments are generally seen in cases of obstructive jaundice. Then we can see pus cells, we can see RBCs, we can see epithelial cells, we can see cast, we can see different kind of crystals like calcium oxalate, calcium phosphate, or uric acid crystal in this urine routine microscopy report. So this is just a picture of USG being taken, and just wanted you to understand how kidneys appear. So basically, this is the kidney, as you can see. This is the here will be some spine, and this is the kidney, and this is the liver, and this is the hepatorenal pouch, the superior pole, inferior pole, and you can see that we can measure distance. Then this black part, or let's say hypoxic part, is your cortex, and hypoxic part is your medulla. You can always measure the cortex and medullary part. You can see the cortico-medullary distinction can be seen, and this scan can help you to see if hydronephrosis is there or any changes of CKDs are there. So, as we discussed, the intrinsic renal AKI causes acute tubular nephrosis can be because of two reasons. If suppose there is ischemic, if there is suppose there is a prolonged ischemia, all pre-renal causes of your acute tubular nephrosis, let's say major surgery, trauma, severe hypovolemia, overwhelming sepsis, extensive burns. In all these cases, patient will first have perineal AKI, and if the injury is not reversible, if it is prolonged, then because of the chronic ischemia, these tubules will necrose, and then ultimately tubules will be shedded, and that will lead to your ischemic acute tubular necrosis. It means the picture will change from pre-renal to renal AKI. Or there can be other causes where there is a direct nephrotoxicity because of any kind of injury. Generally, this nephrotoxicity is because of combination of your intrarenal vasoconstriction, direct tubular toxicity, or tubular obstruction. Kidney is vulnerable toxic because toxins because we already know that patient this we have got so high blood supply, roughly 25% of cardiac output is being sent to kidney. So it means if suppose a toxin is there in the blood, the a huge amount of toxin will be going towards the kidney. That's how, and kidney filters it, excretes it, and concentrates it, and that's how it can lead to more injury to kidney. Now we'll see how to approach hematuria. If suppose some amount of blood is present in your patient, then how to go further about that. Now understand that if suppose patient is not having any proteinuria, there are no other cells, and only hematuria is there, isolated hematuria is there, then mostly bleed is from urinary tract. Why? Suppose if blood is coming from nephrons or kidney per se, kidney means nephrons. If blood is coming from nephron, then the blood RBC cells will enter your tubules, then it will form cast, RBC cast will be formed. And if some injury is there to the nephron, then podocyte will not be functioning properly, that slits will open and some protein will also come. So what I want to say that suppose if patient is having RBC cast, some amount of proteinuria, then mostly this bleed is coming from your glomerular origin or nephrons. If patient is containing only isolated RBC, intact RBCs, then mostly the bleed is from somewhere down, renal pelvis, ureter, bladder, urethra, or somewhere else. So 2 to 5 RBCs per high power field, if present, this is defined as hematuria, and generally we can use dipstick rapid methods in the IPDs to check for that. But problem with the dipstick test is it has got false positivity. Suppose if patient contains myoglobin that can be there in the urine because of muscle injury or let's say exertion, then this dipstick test will be false positive. Some common causes of isolated hematuria that we should always remember include stones, neoplasms, tuberculosis, trauma, and prostatitis. Suppose if a patient presents to you with hematuria, what you can do? First of all, look for presence of dysmorphic RBCs. Dysmorphic RBCs are basically clean RBCs, RBCs with irregular shape. They will be having lots of basically there are lots of irregularity at their surface. They can present RBC cast. So if patient of hematuria is having some kind of proteinuria with some dysmorphic RBCs or RBC casts are there, then probably you are dealing with a glomerular pathology, and then you go for all these tests. All these tests signifies presence of one or other kind of glomerulonephritis. Suppose somebody is having WBC cast, pyuria is there, then you can look for presence of eosinophils and you can send the urine for your urine culture. Probably you are dealing with a case of pyelonephritis. Or if suppose there are eosinophils, then probably it's a case of interstitial nephritis. Remember, friends, that these eosinophils are not specific for your interstitial nephritis, and they can be present in other diseases also. Apart from it, what you can see, you can look for hemoglobin electrophoresis, urine cytology, you can look for urine list of family members, or you can go for 24-hour urinary calcium or uric acid. What you can do, you can go for a scan, IVP or renal USG. You can see renal USG, if indicated, you can look for retrograde pyelography or arteriogram or cyst. If it's there, you can aspirate it. You can see if the cyst is the cause for this thing. Suppose nothing, you find nothing in these all, then you can go for a cystoscopy. If you find any problem in your bladder, then you can go for a biopsy evaluation. Then you can go for a renal CT scan. You can see any renal biopsy or mass. If suppose you don't find anything, and especially if your patient is stable and the amount of bleed is very less, you can periodically follow up your patient. Now, points to remember while dealing with the patient of hematuria. Gross hematuria with blood clots usually is not an intrinsic renal process, rather it suggests a source from urinary collecting system. It's as simple as that, because if the bleed is from nephron, it has to be tricky blood, minute blood. The gush of blood will never come from nephron. Isolated microscopic hematuria can be manifestation of glomerular disease, but RBCs of glomerular origin are often dysmorphic when examined by phase contrast microscopy. Now remember, what can happen that If the urine slides prepared in the lab, if they are kept for longer time and then they are seen after longer time, then even then because of the dehydration or because of the environmental factor, they can be changing the shape of RBCs. So only dysmorphic RBCs if you're finding, then probably you look also in the methods of the lab preparation. Irregular shapes of RBC can be because of pH changes or osmolality changes. But if you're finding RBC cast also, then you think about glomerular pathologies. Also, when different people will see RBCs in under microscope, there can be a wide amount of observer variability in detecting dysmorphic RBCs. Most common etiologies of isolated glomerular hematuria includes IgA nephropathy, hereditary nephritis, and thin basement membrane diseases. IgA nephropathy and hereditary nephritis patient will generally they will have episodic gross hematuria and that will resolve on its own. And family history is very common in case of your hereditary nephritis. Isolated pyuria generally not seen because pus generally comes in the urine from the blood only. If some pus is there, some blood will be there. So pyuria is generally seen along with the hematuria. If suppose somebody is having pyuria and there is presence of lots of bacteria in urine, then you can think about pyelonephritis. Sterile pyuria means when you are having pyuria in urine, pus cells are there, but you are not able to culture any organism. So if suppose somebody is having sterile pyuria, especially in Indian settings, then you have to think about the urogenital tuberculosis. Some other causes where you can find WBCs, WBC cast apart from infection includes acute glomerulonephritis, tubular interstitial process such as intestinal nephritis, transplant rejection patients. So what happens in transplant patients? They are generally followed and they'll be followed with the help of urinary microscopy. If presence of lots of WBCs are there, then one possibility of presence of WBC in urine is transplant rejection. Now, suppose some patient is presented with some amount of proteinuria, then how to approach these patients? Now, first understand that protein is generally checked by different methods. In the labs, we use acids. We use different kinds of acids to precipitate the protein in the urine. That is gold standard. But in some labs and also in bedside we use dipsticks to assess the proteinuria. We have to understand that dipsticks can have lots of false positive and false negative rates. Generally dipstick test will be false positive if the patient's urine pH is more than 7, if the patient's blood is contaminated with urine, or if the urine is too much concentrated. Also, protein can be missed by dipstick test if the urine is very dilute. Proteinuria that is not predominantly due to albumin will be missed by dipstick screening because these dipsticks they will only they are the reaction which is happening and the color that is coming in dipstick is because of albumin. So suppose if a patient is losing some other kind of protein, for example, multiple myeloma is there, light chains and heavy chains are being excreted, then these will not be detected by this dipstick test. So this is particularly important for the detection of Baines-Jones proteins in the urine of patient with multiple myeloma. These multiple myeloma patients will be missed if you will use dipstick test only. Suppose a patient has come to you with proteinuria, then the first thing you can do, you can always take a 24-hour urine collection and you can see how much is the urine protein excretion. Means you can quantify the protein excretion. Now understand this. Whenever you are having a patient and you want to quantify the urine, always first of all make sure the patient has given the right amount of urinary volume. What happens, patient will start collecting urine in between, once he will go and twice and thrice he will miss the urine. So there can be suboptimal collection of urine. To check for that, what we can do, as we have seen, roughly 20 mg per kg of creatinine is being excreted in the urine. So what you can do, when the report of 24-hour urinary protein creatinine is coming, you can look for the creatinine value. If creatinine value is less than 10 to 20 mg per kg of the body weight, then you can think about that suboptimal urine has been calculated. Okay, so let's see, in this chart what we can see there can be proteinuria from 30 to 300 milligram, there can be 300 to 3.5 gram, or there can be more than 3.5 gram. More than 3.5 gram is also known as your nephrotic range proteinuria. So causes we can see in case of if there's a little amount of protein, this is because of mostly diabetes, hypertension. There can be early stages of glomerulonephritis, especially if there are RBC cars are present. Then severely increased albuminuria can be seen in these cases. We can have intermittent proteinuria, postal proteinuria, congestive heart failure, fever, exercises, and myeloma associated kidney disease can be there. Suppose if patient is having proteinuria more than 3.5 gram, that is nephrotic range proteinuria, then we have to think about nephrotic syndromes. These nephrotic syndromes include diabetes, amyloidosis, minimal change disease, focal segmental glomerulosclerosis. There are many kinds of membranous glomerulopathies and IgA nephropathies. All these causes can also lead to your moderate amount of proteinuria. So points to remember in patient of proteinuria. Nephrotic syndrome is said to be present when there is urine protein more than 3.5 gram per 24 hour. Hypoalbuminemia is there. It means serum albumin less than 3 gram. Hyperlipidemia is then edema is there. Suppose if somebody is having urine protein loss more than 3.5 gram per but there are no other features of your nephrotic syndrome, then we only simply call it nephrotic range proteinuria. Smaller proteins less than 20 kilodaltons are freely filtered but are readily reabsorbed from the proximal tubules. Typically, healthy individuals will have less than 150 milligram per day of total protein excretion or less than 30 milligram per day of albumin excretion. But any amount of proteinuria in the urine is not safe, and it's so not safe, and it can lead to increased risk of cardiovascular diseases. Total daily urinary protein excretion more than 3.5 gram can occur without the other feature of nephrotic syndrome, that is known as nephrotic range proteinuria, as already we discussed. Because of loss of so many proteins in the urine, like antithrombin third, protein C, protein S, or there can be other protein loss. All this can lead to your procoagulant state, prothrombotic state, and that's why nephrotic syndrome patients with heavy proteinuria is at risk for your deep vein thrombosis. Also, because lots of immunoglobulins are being lost in your urine, it can lead to increased risk of infection in nephrotic syndrome patients. Coming to polyuria. Now understand, the amount of urine that is being formed in the anybody's body depends on how much solute load that patient is having. In general, our body is producing in general, our body is producing solutes roughly from 600 to 800 milliosmoles daily. Now, suppose if we are supposed to produce urine at osmolality of plasma, roughly 300, that means 2.5 to 3 liters of urine is sufficient for us to get rid of our solutes. Therefore, the definition of polyuria is if somebody is producing more than 3 liters of urine per day, then he is in polyuria. Average person exceeds between 600 to 800 milliosmoles of solids per day, primarily as urea and electrolytes. If the urine output is more than 3 liters per day and the urine is dilute, total osmolar excretion is normal and the water diuresis is present. So now understand this, what actually they want to tell you. Suppose somebody is having lots of urine production. There can be two things. Either the body has got lots of solute, and these solutes we have body has to excrete those solutes, and because solutes cannot be excreted like this, only lots of fluid is required. In such case, we call it osmotic diuresis because lots of osmotically active molecules are there in the urine, and when they're being excreted from kidney, they're taking lots of water with it. That is one thing. If that is the case, in that case, there will be more than 3 liters per day of urine along with more than 300 milliosmol of urine osmolality. High osmolality, high volume of urine is equal to your osmotic diuresis. As we can see in this chart, this generally happens in case of your patients of diabetes who are having lots of glucosuria, or somebody has taken radiocontrast dyes, somebody has taken some other agents which are osmotically active like mannitol, or somebody is taking high protein diet, total parental nutrition is there. In all these conditions, lots of solids are there in the body. Body has to get rid of them. That's why osmotic diuresis is happening. So suppose somebody is having polyuria more than 3 liters per day, then you checking osmolality. If it is high, then probably you are dealing with a case of solid diuresis. And then now if you see here, we have if suppose the osmolality is less than 50 milliosmoles, that means now, in such condition, when the osmolality is not high, that means lots of water is being excreted. This is known as water diuresis. This happens when somehow the arginine vasopressin hormone (AVP) hormone is not active. If arginine vasopressin hormone is not active, then what will happen? This is also known as ADH, antidiuretic hormone. That means if antidiuretic hormone is not there, lots of diuresis is happening. Lots of uh, let's say less concentrated urine is being formed. So if that is the case, that your osmolality is less, then we have to see, we can take history, we can see for loss in sodium, and what we see, we can see whether ADH levels are high or low. Suppose somebody is not have somebody with that much of your polyuria with low osmolality is having very low ADH level. That means your hypothalamus is not producing enough ADH. If there is no enough ADH, then it will lead to central diabetes insipidus. It means there is no ADH at all. No ADH, no water conservation, all the water is lost. So this can happen in these cases. Trauma is there, some tumor is there, some other kind of problems in the hypothalamic pituitary axis is there, then it can happen. Okay. So other thing is, what can happen that you, if suppose ADH level is very high, even then you are not having, even then the patient is having polyuria. That can happen if kidney is not responding to ADH. Kidney will not respond to ADH in particular conditions, like suppose there is no aquaporin 2 at all, or the distal nephron is not responding because of other defects. Let's say there is your hyperkalemia is there, hypocalcemia is there, all these things are there. If or other toxins are there which already has injured your distal collecting system of your nephron, in such condition ADH level is very high, but even then you are having polyuria. So less points to remember. Solid diuresis, since the urine sodium concentration is less than that of blood, more water will be lost, causing hypernatremia and hypertonicity. Common causes of solid diuresis include manual administration, radio contrast media, high protein feedings, enteral parental, leading to increased urea production and excretion. Excessive sodium loss can be there because of cystic renal disease or Bartter syndrome, and there can be tubulointerstitial processes. So generally, what happens in case of your tubulointerstitial disease, there is some kind of salt wasting. But what happened during post-operative dialysis happens when these tubulointerstitial disease, sorry, tubulointerstitial process when happening, there can be some kind of salt wasting, and this salt wasting can also lead to your osmotic diuresis. Uh, Sodium loss generally is mild in such cases, but it can increase when there is a resolution of your acute tubular necrosis. Large volume of dilute urine, if it is forming, then either there is a polydipsic state or diabetes insipidus. In case of polydipsia, patient is having lots of thirst, patient is drinking frequently lots of water. Because patient is drinking lots of water, blood osmolality is going down. That going down osmolality of blood will lead to less secretion of ADH, and that means more of urine production. More water intake, more water excretion. That is known as polydipsia. So polydipsia can be because of habit, psychiatric disorders, neurological lesions, and medications. In case of your polydipsia, generally what happens, your ADH levels are either suppressed or normal. Okay, so what we can do, we can, in the case of water diuresis and polyuria is happening, then we can always go for plasma AUP levels. If plasma AUP levels are high, then probably we are dealing with a case of nephrogenic diabetes insipidus. If the level of plasma AUP is low, then we are dealing with either central diabetes insipidus, or we are dealing with the case of primary polydipsia. If patient responds to water deprivation, with water deprivation, less urine forms, then probably we are dealing with the patient of primary dipsia. So these are methods through which you can differentiate these similarly appearing diseases. So apart from plasma AAP, nowadays circulating copeptin can be also measured. This copeptin is nothing but it's a cleaved protein from pre-pro AVP, and it can also be measured in your blood, and you can see whether the level of AVP is high or low. Water deprivation test plus exogenous AVP may distinguish primary polydipsia from central and nephrogenic diabetes insipidus, as already I have told you how. And what we can do, suppose we are depriving somebody of water, then this water deprivation test is a long test. We will discuss this in one of our endo lectures, how it is done. So to save the time, what we can do, rather than depriving the patient of water, we can give exogenously, we can give hypertonic saline, so that the plasma osmolality can be increased rapidly, so that then we can see the ADH response. Now, to summarize what we have discussed so far is urinary abnormalities are common in outpatient and inpatient settings. Simple urine routine microscopic examination and 1 USG KUB help to delineate the etiology of the acute renal dysfunction. Presence of RBCs, WBCs, proteins, and various scars suggest renal dysfunction, and if present, should guide the further workup. In the acute setting, pre-renal failure is reversible and can respond to fluid challenge. So here we finish our lecture. I hope this lecture will be useful to you. I have tried my best to make you understand this topic. However, I may not be. Uh, I I may have missed something. If suppose you have any doubt, any problem, you can contact me. And if you like this lecture, if it has increased your knowledge somehow, then it will be good if you can like and share the video, and you can subscribe our channel. And if you have seen this video and you are dedicated enough to read it by yourself, then I have a question for you. I can tell you, and you also know that rifampicin, if taken, then it causes urine color orangish or reddish. And I want to ask you if you can tell me any drug which can cause green urine, or any other drug which can cause blue urine. Thank you for your patience for this thing. I hope I will see you in our next lecture. Thank you.